Thanks, David. Thank you for inviting me to speak today. I have the dubious privilege of having received a diagnosis of borderline personality disorder, or rather emotionally unstable personality disorder, at some point in my psychiatric career in the past. I'm no longer using mental health services, I'm happy to say. I don't know what that says about my personality and its disorder, but I'm happy to say that I'm not using mental health services anymore. But I have had a number of mental health admissions to hospital. And so I've also been for some time a survivor researcher. So I work in the research world from a perspective of having experienced services myself. So basically that means that I'm really interested in how do we bring experiential knowledge to the table when we're looking at mental health experiences of all kinds and treatments. And David has really challenged me to think about public mental health, and it was really interesting to hear Ray's talk as well. I think I've got quite a few threads in my talk that overlap with Ray's, which is quite useful. But yes, David has really challenged me to think about this, because I don't think, I've tended to think in a mental health service related box a lot of the time, not necessarily all the time. But so I'm just going to move to tell you basically some of what I'm going to talk about today. I'm very much informed by friends and colleagues who've also experienced this kind of diagnosis, and also research that I've done around people's experience of therapy, people's experiences of abuse and trauma. And so I feel that this is informed by a range of different experiential knowledge sources. What I'm going to talk about today, but also artists and cartoonists, I hope to be introducing you to as well. I called the talk Bringing Personality Disorder Out of the Shadows, because the first two things that I read when I started preparing for the talk both talked about this diagnosis being in the shadows. And I'm basically going to take you through, how do we get this diagnosis? We've already heard from people about that. Some of the gaps in our knowledge, and what a public mental health response might look like. First of all, what do we talk about when we talk about mental health? Well, as David touched on, very often it's the publicly acceptable face of mental health. Mental Health Week, Time to Talk, Time to Change, all of those campaigns that introduce us to the idea that people can talk more easily about depression, about anxiety. More often it's about those elements of mental distress that people talk about, and mental health, public mental health strategies tend to, as David also touched on, tend to find it much more comfortable to talk about the sort of understandable, if you like, measures, the understandable sort of face of mental distress, mental health, mental ill health. All this language is kind of inevitably complicated, but they don't talk necessarily about the psychoses, the other sorts of diagnoses, and personality disorder is certainly one of the most difficult, one of the most stigmatized diagnoses. And the shadows I'm talking about have been created by both public and professional attitudes. Just a few days ago, somebody who I know told me about a therapist who had described a member of staff as having borderline features. Now that to me is way overstepping any kind of professional boundaries and marks that is acceptable in these terms, in this world about that I would like to see in the future at some point. To sort of, what we do when we create a category like this is that we assume everybody has the same sorts of features. We start to minimize our nuanced understanding of individuals, and instead look for a broad characteristics that are in keeping with the other characteristics that we have listed in our diagnostic category. So we have people who are in very powerful positions. not just psychiatrists, but also therapists who can name and act as gatekeepers to services. And very often personality disorder, borderline personality disorder is what I'm usually talking about, being one of the most commonly used ones. But very often services are they're very often not available to people. I've seen people's experiences of being, refused admission to hospital even when they are suicidal because they've been suicidal too many times. And therefore they are the risk versus the responsibility is being put into the balance, and people are being, if you like, persuaded at the wrong, basically this intervention is at the wrong moment, in the wrong way, at the wrong time, in every possible way. So we know that, as Ray mentioned, about 10% of people diagnosed with borderline personality disorder in this particular case will die by suicide, very likely. We also know from a number of studies, and these vary, 80% is an approximation only, because some studies show different numbers, but maybe about 80% of people who reach that kind of diagnosis have experienced some kind of trauma, abuse or neglect. And I want to invite us to take a really broad understanding of what trauma means. In my personal life, trauma is also intergenerational trauma. So you might have parents who've experienced trauma in their early lives, and as a result of that, they are unable to convey certain beneficial emotions or ways of coping with emotions to the next generation. There are all sorts of ways in which trauma can affect people. So I'd like to include in trauma life events and intergenerational trauma that maybe aren't always assumed to be part of it. Not everyone who has a personality disorder, for example, has experienced sexual abuse in childhood, which is one of the most common sort of assumptions, I think, about personality disorder. And it is something that we need to be aware of. How do we get this diagnosis? Well, I certainly know a few ways I got it. Resistance to medical interventions. Perhaps we don't respond to antidepressants in the way people would like us to. A failure to recover. We keep being unwell. We don't take our pills and go away and get better in the way that the medical model encourages us to think about. So it's a real sort of dilemma for practitioners. A failure of services that turn us away and give us more iatrogenic trauma as a result of the ways in which they think it's a good idea to treat us like naughty children. Symptoms or behaviour that people don't understand or can't sympathise with or empathise with. So there you have, this is Rachel Rowan Olive, who's a really brilliant, I think, cartoonist and thinker, researcher, activist. So these are some of the ways in which you can get a BPD, borderline personality disorder diagnosis. You've made a few suicide attempts, self-harm, suicidal thoughts that are persistent. Your emotions change quite dramatically. Sometimes you might be impulsive. So there she has crossed off all her. And then what is her prize? An insulting label and a lengthy wait for therapy. Because actually, various forms of psychotherapy can be helpful to people with problems of this nature, which I really, really resist calling personality disorder, as I'm sure will become evident. But problems of this kind that are fairly long-standing, sort of, and really problematic, can be really very, very difficult to manage. Therapy is often a way that can be helpful, but it can be really long-term therapy. And sometimes that's not necessarily available to very many people at all. What are the gaps in our knowledge? One of the biggest problems about the biomedical approach and our categorization of people into diagnostic categories is it fails many people and it individualizes some of the massive social inequalities that we live with, that we all live with. And I think, that has been touched on by both Ray and by David. Previous research has focused almost entirely on individual, the nature of the individual or the family, the immediate family. And it neglects to look at the systemic factors. And this is a paper that I read by Cameron and others, 2019. neglecting to consider systemic factors such as the impact of discriminatory health and mental health care practices. So whole social and environmental and political incidents in the world that affect us. Not just poverty, discrimination, abuse. Let's bring abuse out of the shadows, I feel. But it's also racism and the stigma and discrimination, I think ongoing sexism, the sorts of assumptions that we make about people who've, and the rejection by services that adds to this kind of trauma is a really common experience by people with this diagnosis in particular. So other diagnoses carry with them stigma and difficulty, discrimination, such as psychosis, but borderline personality disorder in general does also add to the difficulties because people have for so long deemed it to be untreatable and therefore often turn people away, which actually does add to the trauma. You know, I think that's a really important point. The good news, I thought, when I was thinking about this suddenly, was that public mental health, it seems to me, is at its roots is looking at some of the social determinants of health. And consequently, I think it's got a massive amount to offer to people who experience these kinds of problems and who end up with this kind of diagnosis. Public health as a sort of an overall sort of policy strategy, if it was given enough resources, would be looking at some of these very things that might result in people getting a diagnosis of borderline personality disorder. And I think that, for me, was a sudden realization that there was an open door here that we could actually use. So how would we bring the trauma, the abuse and the neglect that people experience out of the shadows and into this world where this public mental health strategy might be of use to people? In terms of prevention, I'm thinking improve early childhood experiences. There used to be a thing called Sure Start, which was about maximizing resilience of parents to be able to care for children in a very positive way and to overcome some of the disadvantages that some children are born into. And I think those sorts of things have very much dissipated over the years, particularly under Tory governments. Actions to reduce poverty, racial and gender inequalities, and to sustain communities. I was really delighted to hear Ray mention peer support, because peer support around mental health is something that is really close to my heart. Recently, I've been talking to people who are participating in peer support groups, and particularly for people who've experienced sexual abuse. And the power that those groups have to listen to people well, to be able to listen to abuse. We are, as a society, generally no good at listening to abuse. And other people who've experienced it can hear people who have experienced it. That power of peer support is really, really important, I think. Actions to acknowledge and work with trauma, abuse, neglect across communities. So again, it's just really recognising that not all trauma looks the same, and a broad understanding of the different things that have affected people. So one of the things that affected me in my teenage years, young teenage years, was that I was in 2 different road accidents, which left me with an abiding belief that I could feel that I was dying. I felt that I was dying. That I still have that with me. Sometimes it visits me in nightmares and that sort of thing. But quite often when services and policies talk about trauma and abuse, it's often talking about sexual and physical abuse within families, and often doesn't include those kind of complex, those other sort of external life events that suddenly impact upon you. And I think those are just as important as some of the really significant ongoing traumas as well. Finally, I'd just like to say how very important it is and how wonderful it would be to have a whole programme led by people with lived experience of receiving this diagnosis, and to hear their understanding, to hear our understanding of why we think we ended up with that diagnosis. How did we get there? And again, I referred back to Ray's talk and his mention of epistemic injustice, because one of the most significant causes of our continued oppression within society and within services as well is just the societal belief that people with a psychiatric diagnosis or mental health challenges are not credible reporters or witnesses of our own experiences. When we speak, we're so often not believed. Thank you very much.